Good morning, one and all present here. Today my topic is about the pleomorphic adenoma. Introduction. It is a benign neoplasm consisting of cells exhibiting the ability to differentiate into epithelial and mesenchymal cells. This tumor has been referred by a variety of names such as enclavoma, branchioma, endothelioma, and endochondroma. The term pleomorphic adenoma was suggested by Willis, which characterizes the unusual histological pattern of the lesion. Its morphological complexity is the result of the differentiation of the tumor cells and the fibrous, hyalinized, myxoid, chondroid, or even osseous areas. This mixed tumor is entirely of epithelial origin. Coming on to the histogenesis, ultrastructural studies have confirmed the presence of both ductal and myoepithelial cells in pleomorphic adenoma. Regesi and Bezzecchi postulated that the intercalated duct cell can differentiate into ductal and myoepithelial cells, in which latter undergoes into the mesenchymal metaplasia. Hubner and his associates have postulated that the myoepithelial cells is responsible for the morphological diversity of the tumor, including the production of the fibrous, mucinous, chondroid, osseous areas. Finally, Dardick and his associates have stated that neoplastically altered epithelial cell with potential for multidirectional differentiation may be histogenetically responsible for the pleomorphic adenoma. It has shown consistent cytogenetic abnormalities involving the chromosome region 12q 13 to 15, and the putative pleomorphic adenoma gene is FLAG1 has been included in the chromosome 8q and 12. Clinical features is the most common of the salivary gland. The commonest site is 60% in the parotid gland, in which the lower pole is more affected than the upper pole. 10% arises in the deeper portion of the gland. 40 to 60% comprises of submandibular, and 40 to 70 involves the minor salivary gland. This image shows an unusual presentation in the submandibular region. Palate is the most common site of minor salivary gland tumor, which is followed by the upper lip and buccal mucosa. Occasionally, mixed tumors may also arise in unusual locations, for example in cheek along Stensis duct, arising in the accessory parotid gland. The male is to female ratio is 6:4. It's most commonly seen in the 4th to 6th decade, with average occurrence of about 43 years of age. Usually, this pleomorphic adenoma is a painless, low-growing, firm mass, which may extend between the ascending ramus of the mandible and stylomandibular ligament in a dumbbell shape interparapharyngeal space. In such cases, the tumor presents as a mass in the tonsillar fossa, soft palate, or lateral pharynx. In early development, the mixed parotid tumor are usually movable, but with continued growth, the tumor becomes more nodular and immovable. Recurrent mixed tumors of the parotid gland are usually multinodular and appears clinically as multiple small nodules that may seem fixed on palpation. Mixed tumors of submandibular gland typically present as firm, discrete masses within the gland. This radiographic features shows the axial CT scan showing the left pleomorphic adenoma. Axial CT scan showing a well-defined hypodense heterogeneous mass in the left parotid gland. Now coming on to the macroscopic features. It is a mixed tumor, generally appears as well-circumscribed masses with smooth or bosselated surface. Tumor larger than 3 cm tend to exhibit increased surface bossellation. The tumor is usually surrounded by a fibrous capsule of varying thickness. The section is usually solid and white, firmer and translucent. They are predominantly myxoid, which demonstrates a soft gelatinous tissue. Cystic degeneration in mixed tumor is relatively uncommon and is found most commonly in long-standing large tumors. Infarcted or hemorrhagic areas may also be noted in tumors that have been subjected to preoperative fine needle aspiration. Small or large discrete nodules of tumor may be present within the salivary gland parenchyma. These nodules of recurrent tumor are myxoid in nature. Minor salivary gland mixed tumor generally occurs as a well-circumscribed, smooth, firm masses which appear whitish in sections. A prominent fibrous capsule is not apparent, but the tumor is clearly demarcated from the surrounding tissues. Minor gland mixed tumor contains legs, myxoid, and chondroid areas. Now coming on to gross specimen, it shows an intact soft tissue encapsulation and bossellated peripheral morphology. Microscopic features. Pleomorphic adenoma demonstrates a combination of a glandular epithelium and mesenchyme-like tissues, and the proportion of each component varies widely among individual tumors. Food and Fraser in 1954 categorized the tumor into following types. It's principally myxoid and cellular components which is present in equal proportions, predominantly cellular and extremely cellular. The epithelial component forms ducts and small cysts that contains an eosinophilic coagulum. Epithelium may also occur as small cellular nest sheets of cells, anastomosing cords or foci of keratinizing squamous or spindle cells. Certain studies indicate that the myoepithelial cells is responsible for the development of the characteristic myxoid and chondrite stroma. Some myoepithelial cells are rounded and demonstrate an eccentric nucleus and eosinophilic hyalinized cytoplasm resembling the plasma cells. Some tumors may consist entirely of background stroma, while others are highly cellular with little background alteration. There is also an extensive accumulation of mucoid material between the tumor cells, which shows an myxomatous background. Vascular degeneration of these myoepithelial cells results in a cartilaginous appearance. There may also see a foci of hyalinization, bone, and even fat in a connective tissue stroma of many tumors. When the pleomorphic adenoma of stroma is absent and the tumor is highly cellular, it is often referred to as cellular adenoma. When myoepithelial cells predominate, it's a myoepithelioma. The treatment involves a surgical excision. For the lesions in the superficial lobe of the parotid gland, superficial parotidectomy with a facial nerve preservation is recommended. Local enucleation should be avoided because the entire tumor may not be removed or the capsule may be violated, resulting in seeding of the tumor bed. Submandibular tumors are best treated by total removal of the gland with the tumor. Tumors of the heart palate usually excise down to the periosteum, including the overlying mucosa. Rarely, a malignant tumor may arise within the tumor, a phenomenon which is known as a carcinoma ex pleomorphic adenoma. Within the tumors are areas of malignant degeneration of epithelial component characterized by cellular pleomorphism and abnormal mitotic activity. These tumors have histologically benign appearance but usually have a history of multiple local recurrences. Based on the pattern of the growth, it can be divided into three subcategories. They are invasive, minimally invasive, non-invasive. Invasive shows malignant cells penetrating greater than 1.5 mm from tumor capsule and adjacent tissues. Non-invasive tumors are small malignant focus within the center of an encapsulated pleomorphic adenoma but without the violation of the capsule. Now coming on to the prognosis. With adequate surgery, the prognosis is excellent of approximately 95%. The risk of recurrence appears to be lower for tumors of the minor glands. Conservative enucleation of the parotid tumors often results in the recurrences. Tumors with predominantly myxoid appearance are more susceptible to recur than those with the microscopic patterns. The risk of malignant transformation may occur at a rate of about 3 to 4% of all cases. Metastasis occurs several years after the initial diagnosis and may spread to the lungs, regional lymph nodes, skin, and bone. The clinical course is good, but there are few cases which have an aggressive clinical course leading to death in 22% of the cases.